Okay, let's get started. So we're going to finish up cardio today. We have to do a little bit about regional blood flow and some lymphatics, and then we'll take a break, and then we'll start the pulm stuff. The pulm will go faster than the cardio will. We might be able to finish the pulm today. If not, we'll have a little bit left on Thursday, and we have a Kahoot review on Thursday for the exam. Everyone see the video I posted about the drawings with the pressure volume curves and everything? So that's a great way to study. Remember, everything should end at cardiac output. Always work your way up and get to cardiac output. So we're going to talk about regional blood flow. How do we shunt blood from different areas? What types of systems need certain types of blood flow, and so forth. So blood flow is not evenly distributed to all organs and tissues. It depends on the vascular resistance. And what area in our vessels, or which vessels, provide all of this resistance? Arterioles. Okay, remember that. It's the arterioles. They have all that, the muscle layer there. Some have variations. GI tract during digestion, there could be more blood shunted to the GI tract when we're digesting our food. So right now you guys had lunch, so the blood's being shunted to your gut. That's where the whole old wives' tale about after you eat, you gotta wait a half hour before you go swimming, because after you eat, theoretically, in theory, the blood is being shunted to your GI system. Not as much as going to your skeletal muscle, so you get cramps or whatever, but not entirely true. You can swim after you eat. It's fine. Some are constant. The brain and the kidney require constant blood flow. They can't deviate from that. They get messed up. We'll talk about what happens when those two systems don't get constant flow. So remember, we talked about how blood flow between the pulmonary and the systemic circulation, it's in series. The blood will travel through the systemic circulation, then it goes back to the heart, it goes to the pulmonary circulation, it goes back to the system. It's in series. The systematic circulation, though, when you break it out, it's in parallel, which means you can go to one system, another system, and this blood flow can go to the skeletal muscle. This blood flow can go to the GI system. This one can go to the brain. This one can go to the kidneys. So we can cut off by squeezing the arterioles. We can pinch that off. So we shunt blood away from the muscle. Same thing we do when we're cold. We shunt blood away from different areas. And we do it by controlling the arterioles. Coronary blood flow. How does blood get into our actual hearts? The heart needs blood. It's a muscle. It requires blood flow all the time. Blood flow to the myocardium is higher during diastole. Why is blood flow to the heart muscle itself higher during diastole? The heart's relaxing now. It's opening. The muscle is relaxed. All those little capillaries are now open. They're not being pinched from the heart squeezing. So the heart myocardium gets its blood flow during diastole. During systole, the myocardium is contracted, blood vessels are compromised and they're compressed. No blood can get through, so it has to wait till we're in diastole. Tachycardia may present a problem because most blood flow occurs during diastole, so the faster your heart goes, the less blood is in the tissue. So if you look here, we have aortic blood pressure and we have coronary blood flow. Blood flow is highest during diastole. Blood flow is highest in the myocardium, the heart muscle, during diastole. During systole, it's not being perfused. Also, extraction of O2 at rest is maximal. So all the blood that goes through the myocardium that has the oxygen, the heart muscle is going to extract that oxygen, all of it out. It's going to use it all up. Because of that, there's no reserve oxygen that you can pull from in the myocardium because it already extracted all of it. So the only means of increasing O2 supply is to increase coronary blood flow. We can't extract more oxygen as the cells come through. We need to get bigger vessels, so we vasodilate to allow more blood to come through. More blood, more oxygen. So we have to increase coronary perfusion pressure or reduce coronary vascular resistance. So if you're lowering the resistance, blood flow is easier or harder. If you're easing up on the resistance, blood flow is easier. You're reducing the resistance, so blood flow is easier. We have nitric oxide, very, very important for vasodilation. It's the most potent vasodilator we have, nitric oxide. That's why we give nitroglycerin to patients who are having chest pain. The goal is to increase coronary blood flow by increasing the diameter of those coronary vessels. If I increase the diameter of the vessel, more blood will get to the myocardium. More blood means more oxygen, and the heart won't be stressed anymore. You get chest pain because you are ischemic. You're getting lack of oxygen to an area. When you work out, and you work out for a while, your legs will start burning. Why do your legs start hurting after a while working out and running? Lactic acid buildup from anaerobic metabolism. Okay, we don't have enough oxygen, so the myocardium gets stressed out, goes to an anaerobic, and you start getting some chest pain, the lactic acid buildup, and nitric oxide for that. Cerebral, so the brain now. So that was the heart. So the brain, constant supply of O2. Blood flow is relatively independent of the mean arterial pressure. And it does this by autonomic nervous system activity. It has this thing called autoregulation. It's going to auto-regulate the pressure in the cerebrum over these wide ranges of maps from 60 to 130. The pressure and the flow in the brain is going to be constant, no matter if you're on the 60 end of the spectrum or the 130. The pressure through the cerebrum is going to be regulated, and it's done via the arterioles. They're the ones who provide the greatest resistance, and that's a target for our drugs. So, let's look at the picture here. We have this auto-regulation of flow in the black line. If you look on the y-axis, we have cerebral blood flow percentage. So we're at 100% on this part of the line. And if you draw lines down, you'll get 80 to 150. So long as your blood pressure is in this range, you will have perfect perfusion through your brain. Now, if you look at the red line shows people who have chronic hypertension. Because they have high blood pressure going on for a long period of time, this curve gets shifted to the right. So this red line represents what the new autoregulation line is going to be for a patient with chronic hypertension. And if you draw your lines down from that straight line, we get 120 to like 210. This is what happens when people are on high blood pressure. They have high blood pressure. The pressure is higher throughout all parts of the day. They're going to shift this line to the right. So what happens is, if you treat someone who has high blood pressure and you give them medication that's going to bring their blood pressure down to normal, they may wind up on that end of the spectrum because now we're putting them back into a normal blood pressure. What do you think is going to happen to this patient as they start operating in that curve because now you're giving them medicine to lower their blood pressure? What kind of symptoms do you think they would have? Confusion, lightheadedness, dizziness, because now the brain is not being perfused at 100% anymore. Now we're in 75% in that range. Eventually, the brain blood flow will go back to normal once you get used to that change in the blood pressure. What I'm trying to get out of this one is when you change people's blood pressure medications, for the first few days, they may get lightheaded and dizziness because they're still operating on that autoregulation scale pushed out to the right because of the blood pressure. And when you lower the pressure, they're still on that graph, they may get lightheaded and dizzy because their lack of perfusion to the brain. Okay? Brain autoregulation, as long as you're on that straight line, you will have 100% perfusion of the brain through any of those ranges. When you start getting out of those ranges, you get less perfusion. Cerebral blood flow, increased neuronal activity and O2 consumption cause local vasodilation. So you need more brain power, more activity, more blood flow goes to the brain. Like the grandmaster chess players, like the elite chess players, because their brain has to go through so many computations and calculations for all these different moves and possibilities, they actually burn a real high amount of calories during a chess match because of the brain power required. Not to say you guys aren't studying losing weight, but you can study all day, but with chess matches, because of the stress and everything involved, they actually burn a lot of calories. Arterial CO2 pressure strongly influences cerebral blood flow. So we're going to talk about CO2 when we come to the pulmonary system, but CO2 partial pressure really influences cerebral blood flow. Dizziness and hyperventilation are caused by cerebral vasoconstriction when you hyperventilate. So PAs, when you guys were in your pulmonary lab last week, some of you asked me, like, how do I stop hyperventilating? Well, tell your patient to stop breathing deep so much. They won't do it. But if you start breathing deeper, you may get a little lightheaded because of the excess CO2 or the changes in your CO2 causes changes in your cerebral blood flow. Okay. Renal blood flow. Now moving on to the kidneys. Kidneys also require constant blood flow. So the brain and the kidneys have that autoregulation graph. Of the kidneys, of all the organs, they have the lowest O2 extraction of all the major organs. So the top one was what? What extracts all the oxygen? The heart. Now the kidneys, they don't extract very much. Kidneys require very high perfusions necessary for filtration. So we talked the other day about MAP. What's the lowest range we really want to see on a MAP? 60, 65, I have 60 here, but around 65. When you get below this number for a MAP, you don't have the perfusion pressure to perfuse your kidneys. If you're not perfusing the kidneys, what are you not going to produce? Urine. And that's how you can tell status of people by looking at the I's and the O's. How much are they outputting by urine? If they don't have the pressure in the system, kidneys won't be perfused, they will not produce urine. That's why looking at urine collection is very important. Not controlled by metabolic factors. So it doesn't matter what's going on in the body as far as metabolism. It just still requires constant blood flow. Strongly influenced by that autoregulation. We talked about that with the brain and sympathetic tone. Increased sympathetic tone during exercise or the baroreceptor reflex stimulations reduces MAP, which leads to renal vasoconstriction. Do you need your kidneys being perfused when you exercise? Nope. So we can shunt the blood away from the kidneys so we don't need to perfuse it because we're exercising. We don't need blood being perfused in the kidneys. It can happen later on. Because the kidney doesn't extract very much oxygen, it's very susceptible to ischemic damage in states of shock with profound sympathetic vasoconstriction. One of the things you'll see a lot when you do your BMP, the basic metabolic panel, you're looking at BUN and creatinine, which are your kidney functions. People come in with all sorts of things. You check the kidney function because if that starts rising, they can have acute kidney injury due to lack of perfusion of the kidneys. That's where you look at those BUN and creatinine. Splanchnic blood flow is your GI system, that whole area. Receives the highest proportion of cardiac output at rest. So at rest, what's our normal cardiac output? What's a cardiac output? What's a normal number for cardiac output? 5 what? Liters per minute. Cardiac output is a flow. Of that cardiac output, majority of it at rest, that 5 liters is going to go right to your GI system to help with absorption of all the nutrients you ate. Sympathetic nervous system exerts dominant control, causing vasoconstriction and venoconstriction. It does both. So we want to get the blood away from the splanchnic system. Divert that blood to the skeletal system when we need it for fight or flight. And local metabolism increases blood flow after a meal. So just by eating, obviously the stomach will start working again, blood flow will start going into that area. Cutaneous blood flow, going to our skin, helps with thermoregulation. Okay, we get too hot, little capillaries dilate, you get red, the flushed color. That's because blood is now in the skin, so you can start sweating and evaporate and cool off. Stimulation via pain, cold, fear, or low MAP leads to cutaneous vasoconstriction to put more blood flow in different areas. That's why your fingertips are the first ones to freeze off when you get frostbite, because the blood shunted away from all your fingers to go to your organs to keep you alive. Increased core body temp causes your hypothalamic activation, cholinergic sympathetic efferents. It's cholinergic because it's going to the sweat glands to help with heat loss. During a fever, we talked about that in that general phys lecture, shivering, vasoconstriction, increased body temp. When we're very cold, we want to increase our body temp. Shivering generates heat, and shunting blood away from the extremities keeps all that nice warm blood in the core. And again, we talk about when a fever breaks, hypothalamus was at 101, now it set your body temp to 98, but your body's still at 101, so we're hot, so you have to sweat to cool yourself off. Skeletal muscle blood flow during dynamic exercise, 75% of our cardiac output goes to your skeletal muscles. And local metabolism also exerts some control here. So when you start exercising, you recruit capillaries that weren't doing anything at rest. So you recruit them, they open up, more blood flow goes to the tissue. We have the capillaries there, we just don't need them, we don't need the extra blood flow. But when you start exercising, all those little capillaries open up to feed all those muscular beds to get more blood, deliver more oxygen, or glucose to your muscles. And those are the different regions of blood flow. So why would it go certain areas? Make sure you understand that brain and kidney have that autoregulation, so they have constant flow over a wide range of MAP. The other systems don't do that. Okay, capillary microcirculation. Capillaries have the largest collective surface area. Okay, your aorta is what, like 1.5 inches big, 4.5 centimeters or so. That's your one diameter of the aorta. Now you look at all the capillaries in the body, multiply it by the size of the capillary, and that gives you the total surface area for capillaries. It's humongous, and that allows for exchange of nutrients and waste. Diffusion is the most important mechanism for exchange. So the distance a solid has to diffuse is going to make the diffusion go slower or faster. If the distance increases for diffusion, does diffusion go slower or faster? Slower. We're increasing the distance it's got to travel. Diffusion goes slower. Lipids soluble and gases diffuse readily. Phospholipid bilayer. Gases are lipid soluble. They go right through, no problem. No issues there. All lipid insoluble substances have low permeability, and they need to go through openings to get through. Time to diffuse is maximized by the slow velocity of the blood. When the blood is in the capillaries, it's very slow moving. That allows time for diffusion. That's why the aorta, the arteries don't have anything, because the blood goes too fast through those vessels. Not enough time for diffusion, but in the capillaries, it's usually like 1 red blood cell thick, and blood slows down through the capillaries so that you can have all your diffusion go through. And blood flow is least in capillaries because it's shared amongst all those parallel vessels. So the blood flow is reduced, but the speed goes slow, allows time for diffusion. That's the main thing with capillaries. Slows it down to allow for perfusion. Transcapillary fluid flux. So basically what we're doing, we want to know, we have factors that favor filtration. What's going to favor fluid leaving the capillary going into interstitial space or going into a cell? We also have factors that oppose filtration. So we have 2 things we've got to worry about. What favors filtration, and we're going to call those the push. What's pushing the fluid out of the capillaries. And we have the factors that oppose filtration, and we're going to call that the suck. We have push and we have suck. What's going to suck the water back into the capillaries and what's going to push it out of the capillaries? That's what we're talking about now. Movement of the solvent, the water, the plasma, whatever's going to move back and forth. What favors filtration to push it out, and what's going to bring it back in. If they equal, will there be any movement? No. If the factors that favor filtration are higher than the factors that oppose filtration, which way is the water going to move? Out. If the factors that oppose filtration, the suck, are greater than the forces that favor filtration, where's the water going to stay or go? In the capillary. It's going to get pulled back in, get sucked back in. So keep this in mind as we go through this section. So here's our Starling's equation. And this is the equation. You don't have to memorize this equation, but this explains to you how we get the factors that favor filtration versus the ones that oppose it. So we have we have 4 variables. We have capillary hydrostatic pressure, and that's always going to be the big P. Big P is referring to the hydrostatic pressure. And it's the force pushing fluid out of the capillaries. So this is favoring filtration. This is the push. Hydrostatic pressure is usually 35 millimeters at the arteriolar end. We have the venous end. So hydrostatic pressure is about 35 here. And it's about 15 on the venous end. Why has hydrostatic pressure gone down as you go along the length of the capillary?
Lower pressure in the venous.
What? So what are we doing with hydrostatic pressure? Pushing fluid out, right? If I'm pushing fluid out, as you go along the length of the capillary, eventually you're going to have less and less volume because you pushed it out. If there's less volume at the venous end of the capillary, the hydrostatic pressure is going to go down. We need it to go down because we want filtration to stop at some point. We don't want to keep pushing all of our fluid out. We need to have it stop so we can maintain a normal volume. We have interstitial hydrostatic pressure, and this usually should be near zero. Hydrostatic pressure in the interstitial space. Okay, that should be around zero. Again, this is still push, forcing fluid movement into the interstitial space. So we have on this side of the equation the P's, these are the push. Pushing stuff out. These favor filtration, leaving the capillary, going into the interstitial space. Then we have other factors. We have still capillary pressure or interstitial pressure, but now we're talking about oncotic pressure. And oncotic pressure has a little pi symbol. And there's a C next to it. It means it's the oncotic pressure of the capillary. And if it's the I, it's interstitial oncotic pressure. Whenever you think of oncotic pressure, it's plasma proteins. So the plasma proteins is what generates the oncotic pressure. The suck is generated by proteins in the blood. So this is the suck. It's pulling fluid back into the capillaries. That's the job of these proteins. Normally, it's about 25 in the capillaries, 25 units of oncotic pressure in the capillaries, favoring the suck to come back in. That's the capillary oncotic pressure. Now we need to talk about the interstitial fluid oncotic pressure. So way back, very first lecture, we talked about the different compartments and what in those compartments we have intracellular fluid, extracellular fluid, and the interstitial space. And I said at that time, there should never be any proteins in the interstitial space. This is why you don't want proteins in the interstitial space. If you are leaking proteins out of the blood and it's going into the interstitial space, what's going to happen to the oncotic pressure in the interstitial space? It's going to go up. As it starts going up, what's going to happen to that difference of oncotic pressure from the capillary into the interstitium? Is that gradient going to get wider or more narrow? More narrow, because we're adding protein, we're adding oncotic pressure into the interstitium. If that gradient goes down, the force that's pulling and sucking the water back into the capillary, will that go down or go up? It goes down as well. We're looking at differences between one side versus the other side. If the interstitial proteins start going up, the forces that oppose filtration are going to get weaker. And if they get weaker, where's this fluid going to wind up? In the interstitium or in the capillaries? This is going to be in the interstitium because the forces that favor filtration are very strong, but the oncotic pressure is getting weaker. So we're going to start getting fluid in the interstitium. What do we call that when you get fluid buildup or accumulation in the interstitial space? Edema. That's how you get edema formation. One way is protein. You reduce the oncotic pressure. What organ makes proteins for us? Liver. If you have liver damage, what are you not going to be making a lot of? Proteins. What's going to happen to your capillary oncotic pressure for those patients? It's going to decrease. They're not making the proteins, oncotic pressure goes down. What filtration pressure is going to win, the push or the suck? The push. That's why liver failure patients get edema, because they don't have the protein to provide the suck anymore to bring the fluid back into the capillaries. So they fill up with fluid in the interstitial space. That's liver, dealing with oncotic pressure. Let's talk about fluid overload. Either it's heart failure or kidney failure, but your volume, your blood volume is going skyrocketing, very, very high. When blood volume goes up a lot, which pressure is going to be affected? Hydrostatic pressure. And in cases with people with heart failure or kidney failure, all this extra volume of blood skyrockets that hydrostatic pressure. It's stronger, much stronger than the suck with the proteins, and you fill with fluid. So hydrostatic pressure, when that starts to go up, that's going to push fluid out. But what keeps our volume stable is the oncotic pressure. So remember, oncotic is the suck, hydrostatic pressure is the push. So here is our capillary. We have the arteriolar end, we have the venular end. We have the hydrostatic pressure gradient, capillary minus the interstitial space. What's that number? And if that number is greater than the oncotic pressure that's set up from the same capillary to the interstitial space, then you're going to get filtration. So on the arteriolar end, it makes sense to have filtration. What are we going to be pushing into the interstitial space, into the cells? What's diffusing? What's the purpose of oxygen, glucose, other things, okay? On the venular end, makes sense to pull things back in. What are we going to pull in now? CO2, urea, waste products. Now we're going to pull those in on the venous end so it can be brought out to the lungs so we can exhale the CO2, or it'll go somewhere else to get rid of. Okay, so on the arteriolar end, hydrostatic pressure wins, so we have filtration. On the venular end, we have oncotic pressure winning, pulling, sucking the fluid back into the capillary, bringing in the waste products and whatnot. This picture here just shows it graphically. The change in hydrostatic pressure is greater on the arteriolar end, but on the venous end, we get net fluid reabsorption because the oncotic pressure is greater. So when you're studying this section, just remember, is it a push or is it a suck? Is it a hydrostatic pressure winning? It's going to push. If oncotic pressure is greater, it's going to suck fluid back in. Everyone good on lymphatics, how capillary circulation works? Okay, so all of our lymphs are all around. The only places we don't have lymph is in the brain and the heart, but everywhere else has lymph tissue and glands and everything to filter all this stuff out. The lymph system is permeable to fluid and protein. So if any protein does get into that interstitial space, if your lymph system is working well, it's going to pull the proteins out, put it back into lymph system circulation to maintain that oncotic pressure gradient. So the lymph system, the main purpose is to resist edema formation. It's going to pull those proteins out, pull that extra fluid out of the interstitial space, get it into our lymph, which we can drain it into our venous system, and we can get rid of it that way. So that's what happens with our lymph system. We make about 3 to 4 liters a day of interstitial fluid, and it gets into our lymph system and brought back into our venous system. So we're constantly recycling this stuff. Uptake of lymphatic fluid resists edema formation. Okay, always know where that protein is, because that protein is going to alter the oncotic pressure, which is the suck. Okay, so any protein that enters lymphatic system from the interstitial will get cleared out by the lymphatic system. So when that protein gets spilled into the interstitial space, the lymph system will pull it out to maintain a zero oncotic pressure in the interstitium. You don't want oncotic pressure in the interstitium. You don't want proteins there. If they do, the lymph system pulls it out. So causes of edema, we talked about this already. Most common is due to increased venous pressure, which is high hydrostatic pressure, heart failure, venous obstruction, other ways to do it. Generalized edema due to low serum protein. This is your liver failure. Inflammation or sepsis makes capillaries very leaky, so proteins start to leak into the interstitial space when you have an injury or inflammation. So, I'm sure all of you at some point have like sprained an ankle or something and hurt yourself, and you get inflammation, right? The skin gets inflamed, the area gets inflamed. It can cause pain when you move that joint because of all that swelling. Why do we have swelling? Because when you get injured, we get increased proteins leak into the interstitium. When that happens, what happens to the pressure of the suck? Decreases. We have protein in the interstitium. So in this case, fluid is going to be filtered out into the interstitial space, or is it going to be pulled back in when you have inflammation? It's going to leak out. The hydrostatic pressure is high, but the capillaries are very leaky, so these proteins go into the interstitial space, reducing the suck, favoring filtration, so the fluid stays in the interstitium, causing you to have swelling. The fluid doesn't go back, and you get swollen joint. Capillaries leak, proteins go into interstitial space, oncotic pressure is reduced, and you get swelling. Lymphatic blockage, if you ever heard of lymphedema. Okay, we know the lymph system is supposed to resist edema formation, but in cases of like morbid obesity, the lymph system is blocked and clogged because of all the fat. It compresses the lymph nodes and all the vessels. You get lymphatic blockage, that fluid can't drain, and they swell up really, really, really bad. So lymphedema, you block the lymph system, it can't drain the fluid's going to get stuck in the interstitium, causing the swelling to happen, the edema. This is just a quick little tidbit talking about edema. In congestive heart failure, the heart just can't pump the blood through the body. You get bilateral edema and bilateral ankle edema. Both legs are going to swell up. If you have a deep venous thrombosis, a clot just in one leg, just that one leg is going to swell up. So if you're seeing a patient who's coming in with swollen legs and both legs are swollen, the odds of that being a DVT are very, very, very low. More likely going to be CHF, kidney failure, stuff like that. But a DVT will have only one leg swelling. And we're done. So we'll take a break, come back at 1:20, and we'll start palm.